All set. And you're on.
All right, perfect. Thank you. All right, good evening, everybody. And go back one slide here. All right, welcome. So those of you have not heard me speak before, my name is Dr. Hofmann. I am a orthopedic surgeon over at Boston Bone and Joint Institute. I'm the junior member of the foot and ankle division. And I was asked to give a lecture this evening. So I chose a topic that I think is pretty relevant to nursing and physical therapy. Looking at ankle instability on its effects on the peroneal tendons and sort of the way that we approach these types of problems, and obviously look at them from a surgical perspective. So feel free to ask questions along the way. So I'll save some time for questions at the end as well. I have my contact information at the end in case anything else does pop up or I have questions along the way. So this is meant to be sort of interactive, so feel free to jump on if you need to. Overall, nothing to disclose. There is some CMA credit for this lecture as well. So there'll be a link at the end. If you guys could please fill that out, it'll be in the chat box towards the end of the lecture. That'll get you credit for tuning in tonight, and hopefully it's something that you learn a little bit from. So let's talk a little bit about the anatomy of the ankle. So in general, there are three ligaments that we are most focused on. It's the anterior talofibular ligaments, the calcaneofibular ligament, and the posterior talofibular ligaments. You can see these depicted in both the schematic and the image above, as well as MRI imaging to the bottom right. In general, the ankle is most stable posteriorly. What that allows is for the ability to plantar flex and maintain the ankle in a plantar flex and dorsiflex position without the risk of subluxation. There are certainly subluxation events that can happen, but what we're going to talk about tonight is really instability, which is not necessarily a subluxation event, but more of an instability and more of a laxity type of event. So that really affects the ATFL and the CFL. You can see these depicted in red on the image to the right and then yellow on the image to the left. We'll see some other MRI scans. But just to get you oriented, this is over the lateral aspect of the ankle primarily. In addition, there are two tendons that run in close proximity to the lateral ankle ligaments. These are the peroneal tendons, which you can see depicted here. There's a peroneus brevis tendon and a peroneus longus tendon. The peroneus brevis tendon runs sort of within the fibular groove. It tends to be closer to the bone, as you can see it depicted in the MRI image to the bottom right. These tendons are covered by what's called the superior peroneal retinaculum, and what that is a covering, almost think of it as a ceiling or a tunnel where the tendons can kind of run underneath and throughout, and that allows the tendons to stay located where they belong, but also can allow for motion and for translation of the tendons. Now, that can become an issue, which we'll talk about a little bit later. If that retinaculum is disrupted in some way, that can lead to tendon dislocation, which is certainly a little bit different than joint dislocation, but something that again, we do see from a time-to-time basis is associated with ankle instability. And so while these are distinct structures, there certainly is a relationship between the two for sure. So this is our general overview of the anatomy. Again, in general, the tendons run superficial to the ligaments themselves. And what that portends is again, a slightly higher risk depending on the position of the foot. So let's talk a little bit more about the tendons in particular. In general, there's what's we call a watershed area, so an area of relatively poor blood supply. And where that is located is what we call zone 2, so just sort of posterior to the fibula itself. There's zone 1, which is above that level of zone 3, which is more into the hindfoot. But this is an area where the tendons tend to be damaged. Now, the reason that they can be damaged is because of some of these anatomic variations. So in general, the peroneus brevis tendon, given its location, is more commonly damaged as it sort of runs and rubs along the side of the bone. What that can entail from time to time is low-lying muscle belly. What that means is that the muscle for the tendon, which obviously is attached more proximally in the lower leg, can sometimes travel down into the tendon, into the fibular groove itself. And what that can cause is some rubbing and some friction, which can then irritate the tendon, causing a tendon tear. Secondarily, as we saw on the previous slide, the two tendons can be called subluxate and within and around each other. Those are subluxations, again, within the sheath, not so much outside of the fibular groove. But if those tendons are rubbing against each other within the sheath, then that can cause some friction and some tearing of those tendons. And the last thing, there happens to be an accessory tendon called the peroneus quartus muscle. That can also lead to this overcrowding phenomenon within the peroneal tendon sheath. You can see that depicted by the small yellow arrow, the images below. And while the native peroneus brevis and longus tendon are intact and are in place, that peroneus quartus tendon can again cause some overcrowding within that region. That can cause increased friction on the peroneal tendons themselves and causing potential tearing of either the brevis or the longus tendon. So again, it's a very finite area. This is all over the lateral ankle. This is all over, maybe a 2 square centimeter area. A lot of action happening in that region. And again, our focus tonight is to kind of talk about the association between those two things. So let's talk about how ligaments function. It's a very basic level. In general, they act as bone-to-bone stabilizers. They connect two bones together, and they're meant to avoid excessive inversion in respect to the lateral ankle ligaments in particular. You can see those lateral ligaments are depicted, again, in the image below, the ATFL, the CFL, and the PTFL. And again, think about their location on the ankle. Since they're located on the outside part of the ankle, their goal is to reduce and avoid excessive inversion. The tendons have a slightly different function, right? So tendons, again, help to move bones and joints, right? So the tendons are attached to the bones, the muscles are located more proximally. That's the interface between the two. Because the tendons are attached to bones in particular, they can help to move those bones with the freedom of the joints around the area. So again, there's a number of joints in the foot and in the ankle. We're focusing mainly on the ankle and the subtalar joint tonight. But looking at the peroneal tendons themselves, in general, their primary goal or primary function is to evert the hindfoot or bring it to the outside. Secondarily, they can also help to plantar flex the ankle. And the peroneus longus, given its insertion, which is on the plantar aspect of the first metatarsal, also helps to plantar flex the first right. You can see the picture on the right, bottom right here, kind of shows you that mechanism of action of each of those tendons, because even though there's two tendons, they run in close proximity to each other. They're from a similar muscle belly. Their functions in the foot are much different based on where the tendon insertion is, because the peroneus brevis tendon inserts onto the fifth metatarsal laterally. That has more of an eversion moment. And the peroneus longus, as I said, inserts onto the first metatarsal medially, has more of a plantar flexion moment. Again, this comes into play when we talk about the injuries that we're going to see here in a little bit. So let's talk about the ligament injuries first. So in general, when the ankle is plantar flexed, as you can see in the picture to the right here, there is a much higher propensity of injury to the ATFL. The ATFL is lax in that position, and that can cause an inversion injury to the ankle, which again injures that most anterior ligament. When the ankle's in a neutral position, as you can see in the video below, the CFL is also in danger. What that means is that usually there's an association or correlation between the injuries, meaning that they start from anterior, go and they travel posteriorly. So as we saw in the initial anatomic pictures, the ATFL is in front, the CFL is sort of in the middle, and the PTFL is in the back. PTFL being the strongest, that is the least commonly injured. And in this respect, when the foot is in a more dorsiflex position, you can have an ATFL and a CFL injury. To that end, again, it's very difficult to have an isolated CFL injury. That's impossible, but we usually need to have that translation, from the ATFL to the CFL to the PFL in terms of injury pattern. The phenomenon of chronic ankle instability. So again, this talk is more about chronic instability, not so much ankle sprains, which is what we just talked about. What can happen over time is with serial ankle injuries to the lateral ankle ligaments, these repetitive inversion type of injuries, that can cause, that can result in about something called chronic ankle instability, which is basically an attenuation of that lateral ligament complex. And if you think of ligaments again in their basic tenon, they're essentially two rubber bands that connect two bones together. The more those get stretched out, the more lax they get, the less they function, and that can give you this phenomenon of ankle instability. In general, this does not occur after one acute injury. It can, in some rare cases, as it says here, maybe 10 to 20%. But again, these accumulation of injuries, put the ligaments at higher risk, but also put the peroneal tendons at higher risk for injury because those ligaments are unstable. There's a secondary phenomenon called functional instability. And this is a phenomenon where the patients come in complaining of, again, instability symptoms, giving way, laxity, inversion injuries, but their structural integrity of the ligaments actually looks normal on imaging, whether it's an X-ray or an MRI. But again, they've lost some of that functional capacity to those ligaments. They've lost the afferent fibers, they've lost the sense of proprioception, which is balance and stabilization. And they've lost this effective motor control of the ligaments. So while the ligaments may look normal, they're not functioning normally. And again, we define that as functional instability, but again, still falls within the realm of chronic ankle instability. And again, this is really for us as the surgeons to sort of decipher and decode in a way. Again, we have the imaging studies for the most part, but we also have an exam that can be helpful in terms of sort of delineating these types of instability. So let's talk about our examination of these patients in the office, right? So number one, this is called the anterior drawer. We're essentially stabilizing the distal tibia. We are translating the ankle, translating the ankle anteriorly. And you can see we sort of cup the heel from behind. We're basically pulling the heel and the foot anteriorly to see if there's laxity in that ATFL. Again, the foot is essentially positioned in approximately 10 degrees of plantar flexion. What that does is allows us to translate, but really to stress the ATFL in particular, because as we saw before, the ATFL is most likely or most susceptibly injured when the ankle is in plantar flexion, because that's when it's at its weakest. Secondarily, and or concurrently, there's something called the talar tilt test, and this is looking specifically at the calcaneofibular ligament. In this test, the ankle is placed in approximately neutral to 10 degrees of dorsiflexion, because as we saw in the previous video, the CFL is more commonly injured with dorsiflexion. The unique part about the CFL is it actually crosses two ligaments. So it crosses the ATFL. The CFL crosses two joints. So it crosses the ankle joint laterally, but also crosses the subtalar joint. The subtalar joint is a joint below the ankle between the talus and the calcaneus, has its own ligamentous structures and stability, which we won't really go into tonight. But again, the unique thing about the CFL is that it crosses both of those joints. So in a way, you want to be able to isolate the subtalar joint to also specifically look at the CFL. One good way of doing that was with the talar tilt test. The second good way is with this prone test here. What this looks like is this is the non-injured side on the left, the injured side on the right. I'll play this again so you can see when you can look at the translation of that subtalar joint. So my hands are there stabilizing the ankle. And again, basically moving the calcaneus itself. And if you go back and look at the left side one more time, you can see there's a sort of a firm endpoint there as I translate that. So it sort of stops and then will spring back. Whereas the right side here, which is the injured side, the translation really continues and there's almost no firm endpoint. I can really almost move that calcaneus as far as I want to the new aspect. So that's a nice way of looking at the CFL in particular. Again, isolating the ankle joint because the patient's prone, but really evaluating for sort of an isolated CFL injury and or a concomitant ATFL and CFL injury. Next part of our evaluation is radiographs. So there's instability criteria that we use again from a radiographic standpoint. The picture to the right there is an AP radiograph of the ankle. What that's showing is a various tilt or various angulation of the talus. Those two red lines should be essentially parallel, about 3 or 4 degrees of divergence usually. But you can see there's significantly more convergence of those two red lines on that view. And that's again showing this lateral ankle ligament complex is unstable or incompetent, whatever word you would like to use. And that's mostly the ATFL and CFL that are contributing to that. Similarly, on a lateral radiograph, the same anterior drawer type of mechanism, we're looking at translation of the talus. You can see that the talus being the round bone here to the right, you can see the gapping is much more significant posteriorly as opposed to anteriorly. So that talus has been translated anteriorly. You can see my hand in the back here holding the heel. Again, same kind of physical exam maneuver. Now we have a radiograph to demonstrate it, to document that there's instability of the ATFL, and that's allowing the talus to translate anteriorly. Okay, so now we've made our diagnosis. We have a patient in our office. They've had multiple sprains. They have continued episodes of instability. They obviously have concerns in terms of their overall, function and rehabilitation. So how do we start the process of trying to rehabilitate these patients? In general, there's a mechanism called functional rehabilitation, which obviously most of you have heard, and we'll talk a little bit about the mechanics of that. And then we use bracing when the patients are at risk for additional injury to try and prevent that. So give some external stabilization to the ankle when the internal stabilization of the ligaments is not robust enough. Surgery comes down the line when these things have failed, whether they've done physical therapy, home exercise program, bracing, some sort of stabilization exercises, and they're continuing to have symptoms. They are unable to return to their previous level of function. That's when surgery comes into play. Excuse me. What that looks like is, again, recurrent instability despite rehab. Patients have recurrent effusions and recurrent injuries to that area. So they usually swelling over the lateral ankle. You'll see certainly the radiographic and the physical exam and the radiographic markers that we just mentioned before. And these are, again, the patients that have done a lot of different physical activities and different types of rehabilitation and just have not been able to restore their previous level of function. Surgery has multiple facets, which we will talk about in a little bit in terms of the ways that we approach this, especially these days compared to historically. But certainly it's a common surgery that we do for patients that have, again, manifested this chronic instability and are looking to sort of improve their level of function. Now, the reason, the main segue between these two talks tonight is to looking at there's concomitant peroneal tendon pathology. So again, when the ankle ligaments are unstable, and when they're not doing their main function, then the tendons have to work overtime. That puts the tendons at risk. Again, most commonly the peroneal tendons, given their location and proximity to the lateral ankle ligaments. And so when we're doing a workup for lateral ankle instability, we're always looking for peroneal tendon pathology so that we can fix, repair, rehabilitate whatever we need to as part of a surgical procedure to make sure that the patients are not having pain and dysfunction afterwards. So let's dive a little bit farther into peroneal tendon pathology. Again, this is just an anatomy scan here of what the peroneal tendons look like and where they're located, which we saw before. This is a little bit busier slide, kind of showing the rest of the bursa and the retinaculum kind of throughout the ankle, which obviously is a complex area. But specific to the peroneal tendons, we're looking at diagnosis of tendonitis or tendinopathy, which can be the result of a previous tear. But these are more sort of chronic type of pathology. There's both acute and chronic tears that can happen for a variety of reasons. And then there's subluxation or dislocation of the tendons themselves, and that can be one and or both of the tendons from the fibular groove if that superior peroneal retinaculum, which you can see depicted down through here, is compromised in some way, right? So that if that retinaculum is disrupted, then the tendons themselves do not have the ability to stay where they belong, and that can give peroneal tendon subluxation or dislocation. So patient complaints in regards to the peroneal tendon specifically. So, like to put behind or ignore the instability aspect of things for a second. What they are looking to do again is to provide additional support to the tendon. If the tendons themselves are in a compromised position, which you can see to the right here with sort of a cable varus or high arch foot position, that can cause increased risk to the tendons as well. An exam finding, you're looking at pain, swelling of the peroneal tendons. There could be localized tenderness. There certainly can be reproduced pain with resisted eversion and palpation. And again, thinking back to how the tendons themselves function, whether it's resisted eversion and or plantar flexion of the first ray, that can give you a sense as to which tendon itself may be injured. And gives you a sense of what the underlying pathology is. But in general, this swelling of the peroneal tendons is pretty classically seen, pretty obvious from a physical exam standpoint. Again, this is primarily localized in that zone 2 region we were talking about before, but can be found in zone 1 and or zone 3 as well. And I will tell you that the tendon tears in general tend to traverse multiple zones, so they're not always confined to one zone. And again, some of the tendons is not always obvious on an MRI, so it takes a surgical exploration to really determine the extent of the tear. Tears and tendonitis on an exam go very much hand in hand. However, it's very difficult to elucidate a tear, but so I should say a partial tear and or tendonitis or tendinopathy on an exam. Again, patients will have swelling, they'll have pain, they'll have pain with resisted eversion. They may show weakness in either case. So just because they have weakness doesn't mean that they have a tendon tear. If there's a complete rupture, that may be a little bit different, but again, that's also hard to evaluate just based on the physical exam. We know the association with ankle instability that we just talked about. Again, we talked about some of the other etiologies before in terms of what might be causing, impingement or additional stress on those tendons, including those other factors that we see sometimes within the fibular groove itself, such as that peroneus brevis muscle belly and or the peroneus quartus tendon. In general, this is a picture of a peroneus brevis tendon tear. You can see the brevis tendon tear where the forceps is between through here. This is the longest tendon below that, which looks intact and normal in that respect. But you can see some tendinopathy of the tendon through the central portion here, and obviously the chronic partial tear of the tendon through here. So not a rupture, but it's sort of an interstitial partial tear, again, most commonly in zone 2, which means that in this picture, the fibula would be sort of right in this region here, and the tendons are traversing from above here down below towards the lateral foot. The peroneus longus, in contrast, tends to have more of a tearing at the peroneal tubercle, which is more in zone 3, and that's more distal into the foot here. It traverses under the cuboid tunnel. So if you think of it, here's the fibula here, the talus is sort of below the tendons here, the calcaneus is below here. The cuboid is the next bone distal to that. So in this region here, as the peroneus longus tendon, which is here, traverses down and through and under the tunnel, that tends to be where it's most commonly torn and or ruptured. In general, again, the split tears are interstitial or within the fibers of the tendon. The longest tendon is much more susceptible to ruptures, given what we just talked about regarding its position in the cuboid tunnel. Here's an MRI imaging of a peroneus longus rupture. You can see the white arrows, excuse me, are depicting sort of an empty space here. So this black circle here is the peroneus brevis tendon. Same thing over here, just for reference, and same thing down here in panel C as well. But below that, there should be another tendon, which would be the peroneus longus tendon. And again, you can see this white space here where there's no tendon traversing that. Looking more proximally in panel D, here's the end of the peroneus brevis tendon, retracted and more proximally. As it's now ruptured, and so there's no connection between this and the distal part of the tendon, which is somewhere down in the undersurface of the foot here. Here's the peroneus brevis tendon for reference. It's going down and attaching to the fifth metatarsal, which appears intact in this MRI imaging. But this is a good depiction of a peroneus longus tendon rupture. Problem with the ruptures, and again, this is not quite the point of this talk, but the problem with the peroneus longus ruptures is that they're very difficult to repair primarily. The two tendon edges separate a far amount. The distal aspect of the tendon edge is much farther into the midfoot. It makes it much harder to retrieve and sort of suture the ends of the tendon back together. So we'll talk about that special case and a little bit about what we do. But if there happens to be a rupture, one of the two tendons, the longus, is more common and much more difficult to treat. So now transitioning to peroneal tendon subluxation dislocation. So assume for a second that the tendons themselves are normal. There's no tear of the tendon, but they're not contained within the fibular groove where they belong. The underlying risk factors for this actually pretty similar to peroneal tendon tears. It's either overcrowding within the sheath itself from the things that we talked about before, or in some cases, there's what's called a shallow fibular groove. What that means is that the space behind the fibula is not really wide or deep enough in that respect, in order to contain the tendons where they belong. And so that can be an injury to the superior peroneal retinaculum that we talked about before in terms of the covering, or it can be isolated to the fibula itself and sort of the anatomic variance that may be there. Mechanism of injury for this diagnosis in particular is actually a little bit different. So usually the peroneal tendons are injured with an inversion type of mechanism of injury, very similar to an ankle sprain, which is what we saw earlier on. In this respect, it can be an inversion, but again, the ankle tends to be in a more dorsiflex position, and that allows for contraction of the peroneal tendons. Because again, they're trying to stabilize the ankle, right? So if the ankle ligaments again are in a chronic situation are lax or not doing their job, and the tendons are trying to stabilize the ankle, that's when they can be most likely injured, which again would usually respond with an injury to the superior peroneal retinaculum, which would then cause the tendons to dislocate. And if anyone has had this happen, it's a very distinct event. This is not like I think something bad just happened. Like people know this happened immediately, and they can tell the tendons have popped out. Sometimes they'll relocate by themselves, but usually this is a relatively dramatic finding, especially in an acute situation. And then if it recurs, it's a continued sort of popping and snapping sensation, which patients will demonstrate or will disclose to you. This is a picture of what that looks like. So you can see the tendons. Here's the back corner of the fibula where the tendons belong through here, and this is obviously where the tendon itself is now dislocated over the fibula itself, and it's sort of lying on the outside part of the ankle with again this sort of dorsiflex inverted position of the ankle. Now I will tell you that there are patients that have chronic idiopathic subluxation, meaning that they are people that can dislocate their peroneal tendons and have dislocated their peroneal tendons, but it's not pathologic. Again, for whatever reason, that may be the source, but it's always important to examine the other side to make sure that it's not an idiopathic finding or a genetic finding, something that may have occurred from an injury itself. But this is again what it looked like on a physical exam. Just very quickly, there's a classification system that we use, which is not all that demonstrative in terms of the talk itself, but just looking at the injuries to that superficial peroneal retinaculum. You can see, the SPR is this branch coming across here. Here are the two tendons, the brevis tendon here, and the longest tendon here. Again, this is a normal fibular groove, right? So you see the sort of concave orientation here. And again, if this is injured in one of these 4 grades here, you can see how those tendons will start to subluxate out of the way, right, or dislocate out of the groove. So here's grade 1 where they're sort of sliding, but still sort of intact. It's not mainly in the groove, but they're sliding out a little bit. And then here's grade 3 where they basically have completely dislocated. This whole rim is lifted off here, and other tendons are basically outside the fibula where they don't belong. Grade 4 being the most rare case here, which is something that we don't normally see. This is sort of a special case, but again, can also lead to the same thing. And this is actually not reducible because in this case, you have the retinaculum attached to the fibula. The tendons have now dislocated, but they have no way of getting back into that groove where they belong. So this being the most rare case, actually the most surgical case. These ones here, we'll talk about sort of our approach for that. But again, like most things, there's different grades to these types of injuries. Okay, so we talked a little bit about the clinical presentation. certainly talks a little bit about the exam findings. How do we tell exactly what kind of type of peroneal tendon pathology we are working with, right? The answer to that is an MRI. So part one, we're looking for a peroneal tendon tear, right? We're looking at the morphology of the tendons. We're looking at any sort of interstitial tearing. We're looking at the location of the tendons. We're looking for fluid within the tendon sheath. And then sort of lastly, or additionally, we're looking at evaluation of the superior peroneal retinaculum. So you can see in this panel on the top right here, this is the brevis tendon split in two. So there's a lobe over here and a lobe over here. And there's the longest tendon there, which again should be only be two circles in that realm. You can see all the white stuff surrounding that is a lot of fluids. We call that tenosynovitis. And that's fluid that's surrounding the tendon because obviously there's an injury of that brevis tendon here. Similar, this is a dislocation picture down below in panel B. So again, here's the fibula depicted here. Here's the groove where the peroneal tendons belong. And you can see with the yellow arrow and the yellow circle, here's where the tendons are now living, which is outside of that fibular groove. So now they've dislocated laterally because again, the superior peroneal retinaculum is somewhere over here disrupted, and now they've dislocated out from where they belong. And then the panel to the bottom left here again shows a peroneal brevis tendon tear. You can see the longest tendon here looks relatively healthy and black. Here is sort of a brevis tendon, which looks a little bit more wispy. You can see that there's a little bit of crescentic interstitial tearing of that tendon through here. And again, MRI is not 100%, but relatively sensitive in determining these tears and depicting these tears. Obviously, dislocation and ruptures are much more easily seen on MRI because it's a much more dramatic situation. The one thing that the MRI is not great at is sort of looking at the degree of interstitial tearing. So what sometimes these look like is a single split interstitial tear where the tendon is sort of separated, but what they really are is multiple split tears in that region because the tendon has been sort of frayed and friable for so long that those tendon edges are not well approximated, and that can be a more challenging repair from a surgical standpoint if we do see that. Similar to ankle instability, the non-operative treatment is actually relatively straightforward. Again, there's a lot of physical therapy involved, immobilization and bracing in some respect. Just sort of a general schematic of some peroneal tendon rehabilitation exercises here. The one thing, and we'll talk about this from a surgical standpoint briefly, but is looking at the position of the hindfoot. And then again, in those patients that have a more varus hindfoot or more high arch or cava varus foot position, that can certainly lead to peroneal tendon problems because it puts more stress on the lateral aspect of the ankle. So if there's a foot problem and an ankle problem, you really have to kind of deal with both. They're not necessarily mutually exclusive from one another. Not so much repairing the foot, but stabilizing the foot using an orthotic to provide some, again, bracing, posting, whatever word you want to use, and then addressing the soft tissue pathology from there is usually most beneficial for patients. But you can see a lot of overlap in this respect between peroneal tendon rehabilitation and the chronic ankle instability rehabilitation that we talked about earlier as well. In general, we're looking at sort of 4 stages. So range of motion, number 1, strengthening, plus or minus peroneal tendon work. Number 2, proprioception, being balance and stability exercises. And then again, activity-specific training, which can obviously run the gamut between sports and work and other recreational activities. So there's a lot of deviation once you get into the activity-specific training. Again, looking at how to get patients back to their level of function and what activities they would like to do. We use bracing a lot in our practice, and it's not from an initial injury, although that's certainly part of it, but also from these more chronic situations. Again, trying to provide some external stability. There's a couple of examples here to the bottom right. But allowing patients to hopefully function at a higher level, again, without needing a surgery to go in and reconstruct some of these areas. Again, protection when involved in sports is also sort of variable. Again, we're more than likely trying to rehab patients from an acute injury or trying to get them through a season so that they can have a reconstructive surgery. That's really the realm that we use them in mostly. We don't really recommend them for sort of day-to-day type of activities and or day-to-day continued usage, because obviously we want things to be rehabilitated so that they can be as strong as they can. And again, sometimes it takes a surgery, but if that's what they need, then that's a reasonable approach, assuming obviously they've sort of exhausted all of their non-operative treatment. Okay, so let's go down that road. So surgical intervention, again, in general, lots of different ways to look at these things, both from a ligament standpoint and a tendon standpoint. I'll give you some examples as we go through here, what we've done in the past, and again, kind of what the future holds here. Most importantly, you want to make sure that you're not addressing one thing without the other. So again, there's a lot of overlap between the ankle ligaments and the peroneal tendons. If again you're proceeding with the surgery, you want to make sure that you are, certainly addressing all of the types of pathology to allow the patient to have their best outcome overall. So we'll go back to ankle instability for a second, ankle ligament reconstruction, and then we'll go back to the peroneal tendons, kind of working back and forth. And again, they're sort of working concert with each other, but the treatments are a little bit different between the two. So the initial ankle instability repair was a doctor named Dr. Brostrom. This was actually developed in 1966 and first published. This is a direct mid-substance repair of the lateral ankle ligaments. I'll tell you, lots of things have changed since that time, but I think historically it's nice to kind of go through this just to have a sense of what we're dealing with here. But in general, this was a benefit for patients at that time. Use of native tissue. There wasn't any sort of joint sparing procedure. There wasn't any sort of allograft tendon or tissue needed. And in general, since it was an anatomic repair, it was able to preserve the tibial-talar and subtalar joint motion. The disadvantages is that you're trying to suture ligaments back together that are not really healthy and they're very attenuated. And go back to the rubber band analogy. If you're trying to stitch a rubber band back together, you can imagine that that's not always the easiest thing in the world. So it had some benefits in the early phases. Obviously, a lot of modifications have happened over time, but this was some of the disadvantages that we found initially from that procedure. Just again, visually what this looks like. So here's a picture where the red and the green arrow are depicting the lateral ankle ligaments that are torn. You can see sort of this cleft in the tendon here. This is actually the lateral talus right here. So seeing in the intra-articular view here, the fibula is the bone to the left here. And you can see that those tendons are essentially kind of pulled off and stretched out from the fibular attachment here. So still attached to the talus down here, but torn off from the fibula here. So what we do is we pass some sutures through each side, basically tie those together. And this is kind of what the repair looks like. Again, bringing those ligament edges together, hoping that heals with the right tension, and then obviously getting the patient to rehabilitate from that. This is an open procedure, which you can see here. Again, sort of the old school ligament to ligament repair. I'll tell you that things have, again, improved over the last several decades here. The initial modification was panel B here, where we also incorporated the inferior extensor retinaculum. So just to get you oriented again, here's the fibula. Peroneal tendons would run behind here. Here's sort of a depiction of the ATFL here and the CFL here. So we've still repaired those ligaments, but now we've added a separate covering of tissue over the top to give it more strength. The next modification was from Dr. Carlson and panel C here. This is actually when suture anchors were invented, and so the anchors then were drilled into the bone. That gave it more bone stability because you had an anchor bone stability for the sutures. The sutures were then passed through sort of the ends of the tendon, of the ligament tissue, which tends to be a stronger tissue, and then they were repaired back to the bone directly. So rather than this ligament to ligament suturing over here in panel A, now it's ligament to bone healing, suturing, which has a much higher rate of healing and is a much stronger repair overall. So that took the advent of new technology. Obviously, we use suture anchors all the time in various places at this point, but that certainly provided the benefit in terms of the strength and in terms of the rehabilitation for these injuries. Moving forward, this is sort of, again, the next level of where we are now. So now we're approaching these surgeries mainly arthroscopically. So this is now an all arthroscopic repair. I've been doing this for the last probably 5-6 years now at this point. And this has a lot of advantages. It's a smaller incision. You saw from the initial picture that we looked at, that was an open incision, which takes some time to heal. Usually heals reliably, but still an open incision. So now this is done all arthroscopically. Again, you can look at other intra-articular pathology. You can look for osteochondral defects. You can look for synovitis. You can take out bone spurs. You can do a lot of other things intra-articularly through the scope with only the same 2 incisions, whereas before they would need multiple incisions around the ankle. The anchors are passed arthroscopically as well, again, through a small incision. I'll show you a couple pictures of what that looks like intra-articularly in a second. Again, for reference, here's the peroneal tendons sort of traversing below the CFL, right? So here's the CFL component here. Here's the ATFL component here. Anchors go into the fibular bone just like we saw. They get passed, again, percutaneously in this respect through both the ligament and this inferior extensor retinaculum, which is here. And then that whole sheath of tissue gets pulled back to the fibula to repair that. There's an additional level of strength that we use sometimes, which is called the internal brace, and I think some of you have certainly seen this before. This is sort of the belt and suspenders approach to the same surgery. So it's still a Brostrom, still a lateral ankle ligament reconstruction. The internal brace is depicted here. So it's a single strand that goes from the talus, just anterior to the lateral process of the talus. Again, also anchors into the fibula, but it provides a bit of a check rein to those lateral ankle ligaments. So you're still repairing the ligaments that you can see here, ATFL here, CFL down here. But now we're adding a belt to the suspenders or vice versa, I guess, to provide more stability to that lateral ankle. This is, sorry, let me go back. This is most commonly used in patients that have had a previous brushing that has failed. They've had some other, soft tissue disorder or connective tissue disorder. I tend to use this more in higher level athletes as well as patients with a higher BMI, just because we want that extra stability, to ensure that their ligaments will heal to the maximum capacity. They've obviously done some biomechanical testing of this as well. So you can see this is the internal brace number here. So 250 newtons versus just the brush alone, which is about 79 newtons. And the native ATFL in a non-injured state is 154 newtons. So adding the internal brace does have a significant increase in the strength of this repair. Again, that allows us to accelerate the rehab and ideally have patients return to play into recreational activities faster. Here's just some pictures from an intra-articular standpoint. So just to get you oriented, the talus is on the bottom, tibia is on the top, the fibula is here in the distance. We sort of cleaned out the scar tissue in this area. This is a drill anchor here that's going in. You can see some of the suture through here. So we drill the anchor into the fibula, just like you saw. Take the drill sleeve out. Here are the sutures that we have. We then pass those through the lateral ankle ligament tissue. So you can see one is passed through the front here. The other one's tucked in the back here in the back corner going down through the CFL. And the number of sutures and number of anchors sort of is a surgeon preference, honestly. It depends on how much sort of strength you want to that repair. You have a fair amount of room in the fibula from a bony standpoint, from a real estate standpoint. So most commonly it's one or two anchors, sometimes three anchors if you're concerned about the stability. But this is kind of what it looks like schematically, intraoperatively. The whole point is this video here. And so if you play this, you'll see, again, just to get you oriented, this is talus on the bottom, tibia on the top. Here's the fibula here. The sutures, you can't see them because they've already been passed down, but you'll see me pulling on the sutures, and I also wanted you to see what happens to the talus as we sort of tighten that construct up. So watch the front part of the corner here. So as I pull the sutures up, you can see the talus sort of popped into play there, right? As I'm pulling them back and forth, you can see that that's really tightening that lateral ligament construct and really bringing that talus back into a more anatomic position, which is here as it relocates there. And again, sort of increasing that stability. And we'll tie the anchors with the talus in that position and make sure that we can make that ligament reconstruction as tight as possible. Because again, going back to the old way, the ligament tissue is not always the greatest. So the tighter we can make it intraoperatively, the longer we think the longer it'll last and be strong for the patients going forward. Okay, let's go back to peroneal tendons now. So now we've talked about the ankle ligaments. That's our sort of our bread and butter in terms of reconstructive options. The tendon tears themselves, again, pose their own sort of complexity. So you have a primary tendon repair. Usually if the tendons are torn less than 50%, and that can be interstitial or even a partial rupture. But we feel confident with a less than 50% tear, we can repair that primarily. That usually just means sutures in the tendon. We'll see a picture of that in a little bit. If there's severe tear or degeneration or rupture in this case, we do what's called a tenodesis or a transfer. So tenodesis is a simple term for basic tendon to tendon transfer, tendon to tendon healing. So if one of the tendons is totally ruptured, thankfully we have the other tendon nearby that we can do with the tenodesis. So we can basically suture those two tendons together. That portends the function more proximally. So now we have two muscles proximally pulling on one tendon distally, and that preserves some function of those tendons at the level of the foot. It's not 100% function for sure, but because of the tendon that we're transferring is usually significantly torn and or ruptured anyway, that tendon wasn't really functioning beforehand. So we're kind of borrowing the other one as a surrogate or as a convoy, if you will, and that allows you to reestablish some strength in the distal part of that tendon, so to again maintain some function in the foot. Occasionally, both tendons are torn to a point where they can't be repaired. In that case, we'll use an allograft reconstruction. That's certainly more complex surgery, much more complex recovery. But again, you're just trying to restore that conduit between the muscle above and the bone below. So whatever way you can get those two tendons to be reattached in some way to restore that function, even though with an allograft it's going to be weaker and not as smooth because it's not native tissue, that does still restore some function to those tendons. Going back to what we talked about before in terms of the heel alignment and the hindfoot alignment, again, that varus heel can be a problem in those patients with a higher arch, putting more stress on the lateral aspect of the ankle ligaments and the peroneal tendons as well. And so if that varus heel is something that you notice clinically, something you may want to address at the same time as your surgical procedure to try and put that into a more neutral position. That includes, in general, either calcaneal osteotomy to sort of shift the heel and or subtalar fusion if there's some arthritis in the subtalar joint as well. And again, the whole point is to reestablish the platform of the foot or the hindfoot itself into a more neutral position so that you're not putting as much stress on that lateral aspect of the foot, given your either recent repair or soon to be recent repair of the ligaments and or the tendons in that area. Right, because if you don't establish the correct foot position and there's continued stress in those areas, the same thing's going to happen as the patients go into the future, even though you may have done a great repair for ligaments and or tendons. So one great way of evaluating the tendons themselves is what's called a peroneal tendoscopy. And this is just like an arthroscopy, like a knee, ankle, hip, shoulder, but this is just looking at the tendons themselves. And so very similar setup to our ankle arthroscopy, same type of instruments. So we use sort of the small joint instruments here. This is a nice technique to get a better look at the tendon. So if there's a patient that comes in with some tendon pathology, MRI is equivocal, doesn't look like there's a tear, and you're going in for a surgery for lateral ankle ligament stabilizations, for example, this is a great way to go in and take a look at the tendons and see if there's a tear in there, right? This doesn't burn any bridges, a couple of small incisions. To look at the tendon, you can see the kind of the view you get here. So the panel to the left is sort of your standard view. This is us working inside the tendon sheath here with the shaver to remove some of that scar tissue and tenosynovitis. And again, once we can get a good look at the tendons, if there's a tear, we can say, okay, we can open that and repair that. If not, we've sort of done our work through the tendoscopy, again, through a couple of small incisions that would save the patient some recovery time. So this is a nice little advent and technique, again, used to identify tendons. We wouldn't do this, in a vacuum necessarily, but it can also be used to treat some of those impingement type of lesions that we talked about before, either that low-lying muscle belly or that peroneus cortex tendon as well, if it tends to be in the way, and we think that's causing some symptoms. Now, peroneal tendon tear, again, don't have a great way of repairing these through the scope. So this is a much more open procedure here. You can see there's a far away view, and here's a close-up of that tendon tear. So again, incision over the lateral ankle, dislocating the tendons, taking a look at it like we did earlier. Again, this is one of those interstitial or split tears of the peroneus brevis tendon. This is again more of a simple type of tendon. You can see a little bit of tendinopathy in where the arrow is depicting up through here. So this is probably acute on chronic setting, if I remember correctly. Here's the peroneus longest tendon traversing below, which again looks intact and looks fine. So this is something that we can repair primarily with sutures. Again, ideally will heal very well. If there happen to be some comminution or some additional interstitial tear and complexity to this, you can always debride that and then repair this side to side with a pretty good, usually an excellent result. And then the last thing you want to evaluate after you repair the tendons themselves, you want to go in, you want to take a look at and make sure that will stay stable within the fibular groove, and address that superior peroneal retinaculum if need be. Now, speaking of specifically a subluxation dislocation event. So again, hypothesize that the tendons themselves are fine, no evidence of tendon tear, but the patient comes in with peroneal tendon dislocation subluxation. Again, thinking about the classification we looked at earlier in terms of where that tear is and how to address it, again, most of them are most to 95% are based off of the fibula. So again, it's a very similar approach to what we've been talking about, right? You make a posterolateral incision, you're sort of looking at the retinaculum, you're taking that off the fibula, you're looking at the tendons to see if there's any tears. But it's a very similar approach from a surgical standpoint. What comes into play is how we repair the fibula to allow the tendons to stay where they belong, right? And in this case, again, lots of different ways to approach this. What we're looking at is looking at the tendons, again, making sure there's no tear, sort of leaving them out of the way, addressing the fibular groove itself. I'll show you some pictures of that, what that looks like in a second. But doing a groove deepening to allow for more room for the tendons. So step one, look at the tendons, repair what needs to be repaired. Number two, evaluate the groove and then deepen the groove if need be. Number three, then repair the retinaculum back to that new fibular groove so that it's sort of as tight as possible, and that way the tendons themselves will stay in place after you've done your repair for that. Again, secondarily, if there's a hindfoot issue, then you want your platform to be as good as you can, not putting stress on that lateral aspect of the ankle. So you can also add in a hindfoot correction procedure as well. Again, sometimes what we'll see in terms of acute fractures, so patients that have a calcaneus fracture, we're going in to repair the calcaneus fracture itself. Again, their foot may have been fine before this, but because that fracture has happened, it's actually pushed the tendons, the peroneal tendons, out of that groove, and you can have an acute dislocation event from a calcaneus fracture as well. So a bit of a more special more special situation in that respect. But in a similar concept, you want to repair the bony anatomy, bony landmarks in that area, whether it's the calcaneus or whether it's the fibula, as well as the peroneal tendons, and then be able to manage that bony anatomy to reduce the risk of dislocation in the future. So this will kind of put everything all together for us. So looking at the peroneal tendons again, this is the retinaculum that's sort of separated here. You can see one sheath of it here. Here's the sort of torn part up here where that retractor is. Again, you can see the dislocated peroneus brevis tendon here. Here's what the brevis tendon looked like after we sort of dislocated it, right? So you can see, again, another interstitial tear, some tendinopathy there. This was probably a more acute tear at some point. But now because it's been riding outside of that fibular groove, you can see a lot of beat up tendon there that needs to be debrided. And then subsequently repaired, right? So there's our tendon repair on the top left corner here. So there's some sutures within the tendon now made it round again. Here's the peroneus longus tendon below, which again, for reference, looks fine. It does not have any significant pathology. You can see one of the distal sheaths through here, so separating the two tendons. So now we have our two tendons in place. Again, you can see this is the backside of the fibula here, where there's just not a lot of room for those two tendons. So you can hypothesize that if we repair this retinaculum, which is here, just to that bone, that these are going to continue to slide and not be maintained or localized within the groove itself. So now we come to the groove here, where our tendons are retracted below after they're being repaired. This is an osteotomy I'm using here to sort of open and crack this fibrocartilaginous ridge behind the fibula. So we're opening the bone itself. We're gonna sort of shift that. And what that does is as we impact that, which I don't have a picture up here, but we've now impacted that piece back here. So we sort of removed this section of bone through here. We've then impacted this corner back through here, leaving the native lateral side of the tendon intact. And now this allows us to have deepened the groove through this area. And what that allows us to do is if we put our anchors or our sutures, as you can see in the picture to the top right here, we then pass our sutures through the retinaculum here. You can see how much more room there is for the tendons below here. So if you look at this edge here compared to the edge from before where that was located, again, it's much more room for the tendons as we've deepened that groove with the osteotome. And now we can do a direct repair of the retinaculum, also advancing that slightly to repair that, to keep the tendons located where they belong, essentially. So there's our passing of our sutures. Here's our final repair here. And again, you obviously can't see the tendons anymore at this point, but we know that they're adequately localized within the groove. We obviously stress this, while we are in the operating room to make sure that there's no evidence of subluxation or dislocation. Tie our sutures down, repair the rest of the tendon sheath, both above here and below. And then have the confidence that tendon repair is, that retinacular repair is going to keep those tendons where they belong. So this kind of puts the whole picture all together here. This is a patient that had, again, peroneal tendon pathology, had a peroneal tendon tear, had peroneal tendon dislocation, subluxation, and a shallow fibular groove. Did the whole gamut of deepening the groove, repairing the tendons, repairing the retinaculum to allow more stability over that lateral ankle. Post-operatively, so this actually is kind of the same throughout the gamut of what we just talked about. So we have a chronic instability, we have peroneal tendon pathology, whether it's tear, retinacular disruption, dislocation, whatever that might be. Do any or all of the above surgeries that we just looked at. We put the patient into a splint for 2 weeks, non-weight bearing, just to keep things protected. Come back as long as the incisions look good, which ideally in this case they're smaller overall because we've done some of this arthroscopically. They then go into a boot at that point. They start a progressive weight bearing program in the boots. They start with a home exercise program, just working on ankle range of motion, because we don't like to stress the retinacular repair significantly early on. That tends to be the most tenuous. The ankle ligament repair is actually pretty strong at that point. But that retinacular repair can be a little bit tenuous. So home exercise program, just getting the ankle moving, kind of keep things as fluid as we can. Start PET at 6 weeks. Again, very similar protocol to what we talked about before. It's range of motion strengthening. Again, obviously the peroneal, since we've done work on those, adding in proprioception and adding in activity-specific training as things move forward. Again, we use a brace of some kind. This is sort of surgeon preference as well. As we're coming out of the boot and starting physical therapy, again, either a lace-up brace for more stability or a mallee train brace, which you see here for support but less stability. And what that allows us to do is, again, continue to rehab them in a protected manner, working on those goals that you see above there. In general, from a return to work standpoint, obviously it depends on the occupation of the patient. Majority of these patients come in, looking for return to sport activities and return to function in that realm, but they all have jobs, they all have things that they need to get back to, and families in that respect. So work is an important part. There's a difference obviously between the left foot and the right foot in some regards in terms of that. But generally, it's 1 to 2 weeks of sedentary duty, 6 to 8 weeks of modified duty as they're, again, getting back into the brace, back into sneakers or steel toe boots, whatever profession they may have. And then we say 3 months for full duty. That can be extended a little bit if they're not more, high intensity type of environment, if they're a police officer or a construction worker where they're on their feet a lot. So that's our kind of a general expected return to work paradigm. And again, it kind of follows the post-operative protocol pretty straightforward. in that they're offered for 2 weeks, working from home essentially in the boot, doing a little bit at that point. But once they hit PT, that's when things ramp up to sort of in a progression to full duty. Sports wise, I like this framework of this protocol. I actually, be interested to discuss with some of you guys here tonight regarding this. But again, just this is kind of injury based, but looking at the sort of the bottom, a few different panels here. Again, this is from a post-surgical standpoint, but again, looking at perceived ankle instability, looking at psychological readiness in terms of return to activity, I think is a huge part of what we do. And then kind of getting into the sensory motor control, which comes with that transition into physical therapy and transition both, from the boot to the brace and then out of the brace to normal, normal footwear. And then again, a return to sport type of evaluation, whether it's a single leg hop test, agility type exercises, ladder exercises, and then again, branching out to sport specific activities and the ability to sort of complete a full, training session in their sport of choice, and what that looks like in terms of getting them back to their activities. So we'll kind of provide patients with this general time frame. Again, obviously, the therapists do the majority of the work in that regard, with our guidance in terms of the benchmarks. But yeah, looking from a sports specific standpoint, I find it very interesting sort of seeing patients kind of traverse that continuum where they don't want to do anything officially. They're really in a splint, in a boot. They're really trying to just recover. Most of them having gone through the surgery are not that keen to kind of push things back. Some of them are obviously more aggressive than others. But the middle panel here in terms of athlete perception, I think is very interesting from a therapy standpoint. How you guys kind of work on that, aside from obviously the soft tissue work and the actual stability work, but working on that with them as athletes or workers or other activities to really get them back to their full level of confidence, knowing that every problem that they had before ideally has been fixed, solved, reconstructed, and now they have the ability to kind of transition back to their previous level of activity, which I think is excellent. All right, so I'll leave it there. I'll leave my contact info up here. Certainly, feel free to reach out anytime if you guys have questions, whether this talk, other talks, whatever may be most interesting for you. Happy to answer questions now as well. I don't think there's anything that came through the chat while I was talking. I don't see any questions there, but if you want to throw a question in the chat, I can answer that as well. Or feel free to open up the grid here. You guys can raise your hand and ask questions if you would like. Thank you.
Thank you so much. And to everybody in the audience, all of our attendees, I just sent the link for the app Smartsheet for the eval tool. Hopefully this does work and you know where to find me if you can't log on to that. But Doctor, thank you very much. It was very, very, very good, very informative.
Great.
And I'm looking at the reviews already, and they look wonderful. Yeah, a lot of thank yous and a lot of rave reviews here. So thanks a bunch. And I see your contact info there, so they can always call you with questions, find you with questions. And
Yeah, for sure.
very
Yeah, email is
impressive.
the
Thank
easiest
you, thank
way.
you.
Happy to talk back and forth too, for sure.